Okay, so today we're going to finish up chapter 13. I know that we went over special senses a couple of lectures ago, so we're going to finish off with the beginning part, actually, of chapter 13, where we talk about nerves, what makes nerves, and the anatomy involved in there, and then a couple of plexes, and then some more spinal cord anatomy, and then I'm going to hit really quickly on the autonomic nervous system, parasympathetic nervous system in chapter 14. So that one I cut down really far. So that being said, we're going to jump right in here to chapter 13. And again, this is all about the peripheral nervous system and nerves, nerve anatomy, how they're made, what they look like, that kind of thing. So the peripheral nervous system is everything that hangs off of the central nervous system. And so this is going to include cranial nerves. There are 12 pairs of those, and so we're going to talk about each of those ones individually. You should know those and what they supply and where they're located. I'll give you guys some worksheets on Blackboard about that. Spinal nerves, which carry impulses to and from the spinal cord, and so those are going to include motor and sensory input. Ganglia, that's just a big fancy term for a fattening of a part of a cell, and that's where there are groups of cell bodies located, so it just looks kind of like a swelling on a nerve. And then we also have sensory receptors. So those are all parts of the peripheral nervous system. The function of the peripheral nervous system is the main communication lines between the central nervous system, brain and spinal cord, and then the other parts of the body. And so this again is going to have motor parts, so things that are coming from the efferent system, and so they're going to be coming from the brain and spinal cord to effector muscles or effector glands, organs. And then also sensory input that's going to go from sensory receptors in and around your body, and then travel that back up to your brain, where then your brain can interpret that sensory information. So nerves themselves are just bundles of axons, and so if you guys remember, an axon is just that long extension off of a cell body that is going to carry an action potential to either the brain or spinal cord, if it's a sensory one, or to a motor unit, if it's a motor nerve or a motor neuron. So nerves consist of parallel bundles, meaning that the axons are running next to each other, of peripheral axons, so ones that are outside of the central nervous system, enclosed in connective tissue. And we're going to look at those types of connective tissue here in a second. Physiologically, they look very similar to the way that muscles are wrapped up. If you guys remember, there was the endomysium, the paramysium, and then the epimysium that wrapped different layers of muscle. Nerves are very much the same. So we'll look at those here in a second. So nerves also can contain myelin, which is that insulating tissue that goes around axons and helps to keep an action potential moving in the right direction. Blood vessels that feed the nerves, and then lymphatic vessels as well. And there are two types of nerves. There are spinal nerves that come off of the spinal cord, exit through the what's called an intervertebral foramen, and then cranial nerves that originate from the brain itself. So the connective tissue coverings include the epineurium, which is on the outside. Remember that epi means on top of, and then the root word neur, N-E-U-R, refers to a nerve. And so again, this looks very similar to how the muscles were organized when we looked at muscles a few weeks ago. So there's an outer layer of connective tissue that holds those bundles together. Then there are perineurium that hold bundles of axons together. And then there's endoneurium, the innermost part, that holds just a single axon. And so all of those are the different layers of connective tissue that hold these nerves together. And so axons, again, bundles of axons together are going to be covered up by perineurium. Bundles of those axon bundles are going to be covered by epineurium. And again, you still have blood vessels in there that feed those nerves themselves. So nerves can be classified one of three ways. They can be what are called mixed nerves, meaning that they have both sensory and motor input. They can be sensory or afferent, meaning that they're going towards the central nervous system. So they're bringing action potentials from sensory receptors towards the central nervous system. or they can be motor or efferent nerves, which means that they're carrying impulses away from the central nervous system. So these are action potentials that are created in the brain and then travel down those motor axons to their effectors, so to the muscles or glands that they're going to stimulate to action. Ganglia, again, are collections of neural bodies that are associated with the nerves in the peripheral nervous system. You've got what are called nuclei if they're in the central nervous system. And so ganglia usually look like a swelling on a nerve, and we'll look at pictures of these here in a little bit, and I'll be sure to point those out for you. But they look kind of like a swelling, and all it is a whole bunch of cell bodies that are kind of amassed together. And again, that makes the nerve kind of look swollen. So we're going to run through the cranial nerves here really quick. I'm not going to spend a ton of time on this, but what you should know for the exam is do know the cranial nerves, so know their name, their Roman numeral number, and then also know very, very superficially what they supply, okay? So there's 12 pairs of them. They're numbered Roman numeral 1 through 12. They are labeled, the way that they're numbered are based on their location. So the anterior most one is going to be cranial nerve number 1, that's the olfactory bulbs. Cranial nerve number 2 is the optic nerve because that actually originates behind the olfactory nerve. Oculomotor nerve is behind that one. Number 3, trochlear nerve, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, hypoglossal, and then the accessory nerve. And so again, they're labeled and numbered based on their location on the inferior part of the skull. So they innervate the periphery of the brain. So this is going to be outside of the brain cavity itself, and so it's not the spinal cord. So cranial nerve 1 is the olfactory nerve. This is going to carry sensory information to the brain, to those association areas. Damage to this will cause something called anosmia, which is the inability or the severe lack of being able to smell or receive that information in the brain. That would suck. So no more chocolate chip cookie smell, no more perfume smell, no more any of that. Your damage is going to lead to the inability to smell. Cranial nerve 2 is the optic nerve. That one carries visual information to the occipital lobe, where that's where those association areas are. And then damage to this can often result in blindness. And so if you jack up your optic nerve, you're probably not going to be able to see very much anymore. Gosh, sorry, that picture is so smushy on there. That's weird. Here you can see up here, you can see that olfactory bulb. So this is your cranial nerve 1. You can see all those little baby hairs that are running through that cribriform plate in the ethmoid bone right there. And they're just going to hang out in the nasal cavity, which they will pick up aerosolized scent molecules and then send that information back to your brain. And then here you've got optic nerve. And so you can kind of see the olfactory bulbs in here. See how they're just anterior to the cranial nerve. And so cranial nerve is optic nerve is number 2. You've got your left and right side. Those are going to cross over at the optic chiasm and then run back to those visual association areas in the occipital lobe of the brain. So cranial nerve 3 is the oculomotor nerve, and so as the name implies, oculo, eye, motor, it innervates 4 of the 6 muscles that move your eyeball around. And so again, there's those 6 muscles. There's the rectus muscles and then also the oblique muscles of the eye. And so oculomotor nerve is going to innervate 4 of those. And so that's going to allow you to move your eyeball around to look at things that you need to look at. If you damage those oculomotor nerve, or if you damage those muscles, you can cause what's called strabismus, drooping of the upper eyelid, double vision, which is called diplopia. Cranial nerve 4, trochlear nerve, and so this is going to innervate the superior oblique muscles of the eyes, and damage to that nerve can cause strabismus, which is again cross-eyed, or like when you have one eye that's not bilaterally symmetrical, so you can be wall-eyed or cross-eyed. And so that guy innervates the superior oblique muscle. Cranial nerve 6, the abducens nerve, is going to innervate the lateral rectus muscle of the eye. And so again, damage to that can cause strabismus, which is the crossing or the wall-eyedness, or diplopia, which is double vision. So there's all those muscles. The rectus muscles just go directly from the eyeball to that back. It's that there's a ring back there, a common ring, that all of them are attached to, that common tendinous ring. Then the oblique muscles kind of go through what's called a trochlea, or like these little things up here that actually cause the muscle to go sideways, and that allows your eyeball to move kind of like sideways and forwards. So here's that lateral, or the superior oblique muscle up here. This is your superior rectus muscle. You've got your medial rectus muscle. The lateral one is cut here, and then you've got an inferior rectus muscle. So remember that rectus just means straight, and then oblique means diagonal. And so you've got 4 rectus muscles in the eye, and then you also have 2 oblique. And so the oblique ones, again, go in. They're going to go through this little ring right here, and then wrap around the eyeball, so that way you can actually turn your eyeball in the socket. And you've got a superior one up here, inferior one right here. So there's 3 cranial nerves that are involved in supplying motor input to the eyeballs themselves. So cranial nerve 5, this is the trigeminal nerve. It's called trigeminal because it has 3 big branches in it. A mixed nerve, so that means it's got both sensory and motor input. This is the one that your doctor tries to hit when he's giving you a little bump of Novocaine before he drills in your teeth. The trigeminal nerve is a big nerve. It's like half your face. So motor supply includes the muscles of mastication, which is the muscles of chewing, which include the temporalis, masseter, and then the medial and lateral pharygoids. Sensory supplies to the face, and those 3 big branches are the ophthalmic branch, which travels through that superior orbital fissure. So think of your anterior skull, that big X fissure that's in the back. The superior part of that is the top. You've got a maxillary branch, which travels through the foramen rotundum. So think about your inferior view of the skull, and that's going to go along the maxilla, hence the name maxillary branch. And then you have the mandibular branch. And so this part is going to exit through the foramen ovale. So again, think of your inferior skull, little foramina, and that's going to run along the mandible. So damage to this can cause really, really nasty, sharp pain to the face, and then also weakness in mastication, which is your, again, chewing action. So there's the trigeminal nerve, and so you can see the ophthalmic branch. So this is the big one back here. So you can see this huge, giant, big ganglia. So we've got a swelling right here of cell bodies. We've got the ophthalmic branch, and that runs right behind the eyeball. You've also got the maxillary branch right here, and then you have the mandibular branch right here. So back here is where your dentist tries to whack that nerve if you're going to be getting fillings or whatever, and that's why you become dead on this part of your face when you get those shots in the back of your mouth. And so they're just trying to deaden your teeth before they drill, so you don't feel it. So thank your dentist for that, because seriously, that would be just wretched if there was no anesthesia. All right, so cranial nerve 7, this is the facial nerve. It's also a mixed nerve, so it's got, again, sensory and motor function. It provides taste information in the anterior, so the front part of the tongue. And the motor function is it allows you to move facial muscles to produce facial expressions. And so this one is also a big one that runs along your face and helps you to create those awful facial expressions when you're staring at somebody and you're mad, and they can tell you're mad even though you haven't spoken to them. So that cranial nerve 7. So let's look at this one. So here you can see facial nerve. So right here we've got what's called the genticulate ganglion, again just a swelling of those nerve bodies, and so this one's going to go up and it's going to go around, innervate the face, and so you can see all these different branches here, and you can see that they innervate all these different muscles. You've got the zygomatic, you've got your levator labii muscles are all innervated, you've got your depressor anguli, your triangularis, and then you've got all these muscles on the side of your face, which are all, again, involved in creating facial expression, and so hence the name facial nerve. And you can see the stems here on the side. You can see where they're coming out of the base of the brain. So cranial nerve 8 is the vestibulocochlear nerve. We talked a little bit about this the other day when we were looking at the internal ear structures. So this is going to be a sensory nerve. It's got 2 big branches, the vestibular branch, which originates from the vestibule, which is the part of the inner ear that's involved in balance and equilibrium, if you remember from talking about that the other day. And then there's also a cochlear branch, which is originates from the cochlea, which is that snail organ in the inner ear, which is responsible for your ability to hear noises. So if you damage this nerve, if you cut off the communication between the brain and that those organs on the outside, so the vestibule, the semicircular canals, and the cochlea, this is going to probably cause you to lose your hearing, so you'll become deaf, and then you can also lose your balance equilibrium. You might have vertigo after that because you're going to lose the ability to receive information about your location and your head's location in space if that vestibular branch is broken, or if that common nerve, the whole vestibulocochlear nerve, is damaged. So here's what that looks like on the inside of the ear, and you can see over here again the rootlets where it stems from the brain, and so here's the whole vestibulocochlear nerve here. Here is the cochlear branch, again attached to the cochlea, and then you've got, or this is the cochlear branch, and then this is the vestibular branch right here. It's attached to the vestibule and the semicircular canals. So if you guys remember, there's like macula and there's little stereocilia in there, and again, those receive information, constant feedback about where your head is all the time. So that's really involved in your ability to balance. So cranial nerve 9, this is the glossopharyngeal nerve. And so anytime you hear glosso, think tongue. Anytime you see pharyngo, think pharynx, which is the back of the very top part, I guess, of the throat. So this is a mixed nerve. It's got sensory and motor portions. So sensory allows you to taste the back third of the tongue. Motor includes the pharyngeal muscles, which are involved in swallowing. So those a lot of times are reflex muscles. If you stimulate those nerves back there, it's going to cause you to swallow. If you damage it, just as you would think you might lose your taste sensation in that back third part of your tongue, which is the part that's innervated by this nerve, and also can lead to difficulty swallowing because those motor neurons are not going to be able to communicate with the muscles of the pharynx any longer. So here you can see, again, he is right back there. This is the rootlet back here from the brain. You can see here's that glossopharyngeal nerve. We've got the glosso part is going to go to your tongue, and then there's the pharyngeal branches, which innervate the tongue and the back of the throat, and again, are involved in swallowing. So cranial nerve 10 is the vagus nerve, and so this is again mixed, passes through the jugular foramen. So think again about your inferior view of the skull. It has sensory and motor components, and so the sensory part provides info from the organs, and so this is going to be information, sensory information from the viscera that will then be transmitted to the hypothalamus, to the cerebrum, where you can integrate that information and then respond to it. Motor components include controlling skeletal muscles of the soft palate, so the back of the throat, pharynx, and esophagus. And so this can affect your cardiac muscle, smooth muscle, and glandular secretions of the digestive tract. You damage it, can lead to difficulty swallowing, again, because it is involved in the motor components are involved with the soft palate and pharynx, and this can cause difficulty swallowing if you damage that. So there's the vagus nerve. Look at how big that guy is. And so we've got a big old branch right here. You can see him originating back this way. I'm going down pharynx, esophagus, all the way down. There's cardiac branches. And again, because the sensory part of this nerve is going to be receiving information from the viscera, all the guts and all that good stuff down here, and then transmitting that back to the brain. So the brain kind of knows what's going on with your guts at all times. And so if we need to respond to any sort of weird stimulus, we can't, because we're getting that sensory information, that sensory feedback pretty much all the time, constantly. So cranial nerves 11 and 12 are the accessory nerve and then the hypoglossal nerve. So accessory nerve is a motor nerve, and so this is going to innervate the neck and upper back. So muscles, deeper muscles can include the soft palate muscles, again, pharyngeal and laryngeal muscles, which is your voice box muscles, the sternocleidomastoid, and your trapezius. And so again, sternocleidomastoid runs along the lateral side of your neck to the anterior portion of your clavicle, and then the trapezius is that big kind of trapezoid-shaped muscle on the back of the neck. That's the one that your boyfriend or girlfriend squeezes when you have a tension headache, and it makes you feel better, and you get your neck massaged a little bit. This nerve also travels through the jugular foramen, and damaging this nerve can lead to muscular difficulty in the muscles that it innervates. So the trapezius, sternocleidomastoid, the actions of those muscles include being able to elevate, so like shrug your shoulders, and then rotating your neck side to side. So doing that like yes and no, or that no shake back and forth. That's really what the sternocleidomastoid is involved in. And so again, if you damage this nerve, you're going to have problems with those motor outputs. So the last one here, cranial nerve 12, this is the hypoglossal nerve. This one provides voluntary motor control to the skeletal muscles of the tongue. And so that allows you to speak. So all of the tongue movements that you need to speak and produce sound, sticking your tongue out, any of those voluntary movements that you're doing with your tongue. So not really the ones that are involved in the reflex swallowing, but ones that you can control by thinking about them. These nerves are going to pass through what's called the hypoglossal canal, which means like under tongue canal. And if you damage this is going to cause your tongue to deviate, which means that it's going to like stick out on the side where there's damage. So there's the cranial nerves, 11 and 12. So you can kind of see on here, there's the spinal nerve or the root nerve, and then you've got external branches of number 11, it's this guy right here. And then you have the hypogloss, or the accessory nerve back here, so this guy right there. He's going to come out and innervate, again, back of the tongue, back up here, so you've got your hypoglossal nerve back here. You can see where it originates from, and it's going to run down hypoglossal, so under the tongue, and also part of the pharynx, and then again, sternocleidomastoid, those types of muscles. I left these in here because I kind of liked the way that these organize that information for you guys, but I really liked this next slide over here. So this gives you mnemonics, and so you know the cranial nerve. So, and again, they're organized based on their position in the skull. So 1, 2, 3, 4, 5, all the way down to 12. So order. So 1, 2, 3, 4, 5, all the way down to 12. You can remember by on old Olympus, towering tops, a famous vocal German viewed a hops. And so that's all the nerves 1 through 12 all the way down. So that tells you the order from the inferior view of the skull. And then this mnemonic over here tells you the function. So whether it's a sensory nerve, whether it's a motor nerve, or whether it's both. And so that one is, some say Marilyn Monroe, but my brother says Bridget Bardot. So kind of a silly mnemonic, but if that helps you, then certainly remember that. That way you can remember if these are sensory, motor, or mixed, or both. So now we're going to talk about spinal nerves. And so spinal nerves are going to originate from the spinal cord. They're going to exit the vertebral column in little holes that are made by the way the vertebrae sit on top of each other. And those holes are called intervertebral foramen. And so that's what IVF, in this case, that's what IVF stands for. We're talking about reproduction, that stands for in vitro fertilization. But here, since we're talking about nerves, intervertebral foramen. So there's 31 pairs of spinal nerves. There are 8 cervical nerves, 12 thoracic, 5 lumbar, 5 sacral, 1 coccygeal. Those numbers might look familiar to you, except for maybe this one up here, because the number of nerves that you have there correspond directly with the number of vertebrae that you have for those sections of the back. So with the exception of the cervical nerves, because you have 7 cervical vertebrae, and here you have 8 cranial nerves, there are 12 thoracic vertebrae, 12 nerves, 5 lumbar vertebrae, 5 nerves, 5 sacral vertebrae. Remember, they're fused together, so they technically are one big mass of bone, but they used to be 5. And then you have 1 coccygeal nerve down at the bottom. So these spinal nerves are going to supply specific regions of the body depending on where they extend to. And we're going to look a little bit more deeply at this here. So spinal nerves, again, they're going to exit from the spinal cord. They have both sensory and motor input. If you guys remember talking about the spinal cord, you'll remember that the anterior portion of that gray butterfly right here is the motor input, and then the posterior horns back here are sensory. And so we're going to have dorsal, which is the sensory input, and then we're also going to have anterior, which is the motor input. Those are going to coalesce together. This is called the dorsal root ganglion. So again, we have a swelling right here. Those are your sensory neuron cell bodies that are all just kind of hanging out here before they exit the spinal column. And those two are going to coalesce together and become the spinal nerve. Once that nerve leaves through the intervertebral foramen, there's going to be horns that come off of that and innervate different things and go to specific areas of the body. Those horns are called rami. So a ramus or a rami just means a horn, okay, so like an extension. So here we've got what's called the rami communicantes, and so these two little guys are going to communicate. This is the sympathetic trunk right here, so this is where your sympathetic nervous system is going to run down and then innervate glands and organs and tissues and things if you have a sympathetic nerve response, so if you are fighting or flighting. So again, the rami are just horns, and there are ventral and dorsal ramus, which you can see on here. So the dorsal ramus is just a horn that comes off of that spinal nerve. His job is to innervate skin and muscles of the back and the neck. And then you've also got the anterior ones, which you can't really see here, but the ventral are the belly side ones. You can see like a little bit of it right there. So the anterior ventral, these are going to innervate skin and skeletal muscles of the limbs. And so these ones are going to form what are called plexes or a plexus, which is a big bridging network of nerves. And there's 4 specifically that we're going to look at in a little bit. There's the cervical plexus, the brachial plexus, the sacral, and then the lumbar plexus, and they serve different parts of the body. So again, I'll show you what that looks like here in just a second when we look at those big nerve plexes, but it kind of just looks like a big network, a big net of nerve fibers that are going to bridge on each other and coalesce together. So I just wanted to show you on this slide where you've got, again, motor input. Again, this is the anterior of that gray butterfly. So this is the visceral motor area. This is the somatic or the voluntary motor area. And so you can kind of follow these back. So the blue part here is going to go out. It's going to coalesce with the sensory stuff here and become the spinal nerve where it's going to exit the vertebral column. So this visceral motor is going to travel down. And then here we've got the rami communicantes, and so again, these are just horns that are called the rami communicantes. There's 2 cords here. The white ramus, which is where that visceral motor is going to go, and it's going to synapse onto sympathetic nerve ganglia. Okay, so this is that sympathetic nerve that you saw running down the front of right here. So this is that front part of the nerve right there. Also have the somatic motor. This is your voluntary motor stuff, and so that's going to come out. It's going to run down the spinal nerve, and it's also going to exit through that dorsal ramus back here. So there's going to be ventral ramus, the spinal nerve, and then also dorsal ramus. And so again, dorsal ramus is going to innervate the skin and muscles of the back, and then the ventral is going to innervate muscles of the body wall and limbs. So more on that ventral belly side. Over here, you can see that the back part of this is the sensory part. You can see our cell bodies right here are going to make a big swelling called a ganglia. And so this is that dorsal root ganglia. You've got 2 divisions of sensory. You've got somatic sensory and then visceral sensory. So this is more of like your skin and outside of the body stimulus that are going to be able to create action potentials in those nerves. And then you have visceral sensory right here, which is information that's coming from within your body. So sensory information that's coming from the walls of the viscera. This is going to be receiving action potentials this way. So that's actually going to go down. And then once that action potential reaches the spinal cord, then you can elevate that up to the brain, and then your brain can integrate that information. And so the ventral cord right here, so again, ventral ramus, this is going to have input from exteroceptors, proprioceptors from the body wall and your limbs. So that's your somatic sensory. And then you've got the purple side, which is that visceral sensory, that's going to be interoceptors of the body wall and limbs. And so stuff that's coming from the inside. So you have stuff coming from the ventral side of the body, and then also the dorsal side of the body, so the back of the body. So all of that kind of coalesces together and becomes that spinal nerve. So again, there is both motor input here and there is sensory input here. Sensory is in the back, posterior is sensory, anterior is motor. If you guys remember, I think I told you guys, I remember that as AMPS, A-M-P-S, so anterior, motor, posterior, sensory. So there are small branches off of the spinal nerves that do supply different things. And so cutaneous branch, anytime you see cutaneous, you see, or you think of this as being skin. So when you talk about like cutaneous membranes or cutaneous, think skin. And so this is going to supply an area of skin with a sensory branch. And so each of these sensory branches are very well mapped on a human body, and those maps where those specific spinal nerves supply sensory information from or to this central nervous system is called a dermatome. These can be incredibly important for diagnostics. You guys have all heard very, probably a lot, especially working in hospitals or around patients, if a patient comes in complaining of left arm and chest pain, you know that that probably means there's a heart problem. So if you investigate the tissue and make sure that the skin of the arm and chest are not damaged, the dermatome there is supplied by a spinal nerve that also supplies the heart. And so sometimes when there is damage to tissue underlying, that can be referred to the dermatome that is also supplied in that same spinal nerve. And so sometimes people will come in complaining of very specific pain in very specific areas of their body. So knowing what those spinal nerves supply underneath in a visceral sense also gives you kind of a lot of information as to what might be going on underneath. And so it may not be that specific patch of skin that's giving them a problem. It may be indicative that there is a problem with the viscera underneath. And so again, like I said, the classic example is someone coming in and complaining of left arm pain, and then you knowing that that's indicative of a heart attack or a heart problem. So cutaneous branches, again, very important for diagnostics. There's also what's called a meningeal branch, and so these, you can like barely see them on here, but I put this picture, and I don't know if you guys have this on your slides or not, but this meningeal branch right here is a little baby projection that's actually going to come out of the intervertebral foramen and then kind of go back in. And that meningeal branch's job is to supply the vertebrae, spinal cord, facet joints, and the meninges with innervation. And so it's going to branch off of that spinal nerve and then immediately re-enter the vertebral canal through the same hole, that intervertebral foramen. And this is where you get sensory and information from the spinal cord itself. And so the meninges, again, the vertebrae, those types of things. So that's what the meningeal branch is for. Where you're looking at spinal nerves T1 to L2, so that's going to be the vast majority of these spinal nerves, are going to have also that white and gray ramus, which is called the rami communicante. So you can see that, dang it, go back here. You can see that right here, these two branches, so that's the rami communicantes. And so those are going to innervate smooth muscles, glands, and organs, and they're kind of hardwired into that sympathetic trunk, which is going to activate when you're having a fight or flight response. So here's those plexes that I was talking about. Look at this crazy mess and tangle of nerves up here. So up here where you've got cervical nerves that are going to coalesce and bridge and network with each other, that's called a plexus. And so this one up here is called the cervical plexus. It supplies the head and neck, upper chest, shoulders with innervation. You also have the brachial plexus, which is this guy right here, brachial plexus down here. You can kind of see that there is cervical involvement here and then also thoracic. So here you've got brachial plexus that is going to supply the upper limbs and the pectoral girdle, so like anterior chest and then the upper limbs. And then way down here you have the lumbar plexes, and so again, network and tangle of nerves, and then the sacral plexes, these guys right here. And again, those are just big networks of nerves that bridge onto each other. They come together, coalesce, and then diverge again. And so these two, because they're so interwound together, are sometimes called the lumbosacral plexus. And so they've actually just concatenated that into one plexus there. But the job of those plexes are to supply the pelvic girdle, so again, the pelvis and the sacrum, and then also the lower limbs, your legs. So cervical plexus is formed by the ventral horns. Okay, so the ventral horns of C1 through C4 and 5. This is going to give rise to what's called the phrenic nerve, this guy right here. Really important, you can see him down here. Phrenic nerve is super crazy important because this keeps your diaphragm working, and if your diaphragm isn't working, you're not breathing. So the phrenic nerve, very important. The brachial plexus, and I'll show you guys pictures here in a second of the brachial plexus, but just bear with me while we're looking at text. Formed by the ventral rami, so those ventral horns of cervical nerve 5 through thoracic nerve 1. Okay, so these nerves are going to pass above the first rib, posterior to the clavicle, so just behind it, and then enter what's called the axilla, and then down the arm. So these are going to give rise to the nerves of the forearm, the nerves of the antebrachium, and then also the nerves that supply the biceps brachioradialis and the humeral bones and muscles of the arm. So the brachial plexus is kind of complex, and so there are the ventral rami that come right out of the spinal cord are going to form trunks. Okay, so there are 3 trunks: superior, which is the superiormost one, middle, in the middle, and then inferior, which is the lowermost one. And I'll show you pictures of this in here in just a second. Again, they're posterior to the clavicles, and so then those trunks are going to divide into another subcategory called divisions. And so there's an anterior and posterior division for each of those trunks, and so that means there are 6 divisions because there are 3 trunks. So 3 trunks, 2 divisions each, 6 total. And in the axilla, this is going to divide into what are called cords. Those divisions are going to, again, network together, coalesce together, and then you're going to have cords that are going to spring forward from this. And so there are lateral, most sideways, medial, and then posterior cords. And then from those 3 cords, you're going to have a lot of branches coming off, and those are going to form the nerves of the brachial plexus themselves that, again, are going to supply the upper arm. So I left this in here because I liked the way that they organized this into like a textural pattern. So the brachial plexus in the upper limb, there's a mnemonic that you can remember the trunks, divisions, cords, and then terminal branches. And so the mnemonic for that is really tired, drink coffee. And so that, again, refers to the ventral roots, trunks, divisions, and then cords. Okay, and then from there, we're going to branch off into the major nerves, the actual nerves that supply the muscles and supply the sensory input for the upper arm. So look at what you got there. So the roots, again, those ventral rami, the roots that come right off of the spinal cord. So they're in blue right here. So you can see it's C4 through T1. Then you have trunks. So these ones right here. Again, upper, middle, and lower right there. Then you have posterior division and anterior divisions. Then you have the actual nerves right here that are the anterior division, and then you have posterior division nerves as well. And so here's the actual nerve branches. You've got the axillary nerve, musculocutaneous, radial, median, ulnar. Some of these you're going to know kind of where they end up just by the names, like the radial is going to end up by the radius. Ulnar is going to end up by the ulna. So let's look here. So here you can see on a real live dead person what those plexes look like. And again, lots of overlapping, lots of networking, lots of bridging from one nerve to the next. And so you can see all the plexes up here and then all of those nerves and how they run down the arm. In this drawing here, you've got, again, radial nerve, the musculocutaneous nerve. You've got the ulnar nerve right here, runs down the ulna. And then you've got the radial nerve that runs right down the radius. And you can see where some of those branches go. So you've got a lot going on here. The median nerve, this guy right here that starts way up the top. So the median nerve is going to run down and it's going to innervate the palm of the hand and then also the phalanges. And so this is going to diverge as well into the fingers and into the palms. So we already talked about these different nerves. I'm going to run through these just real quick. So musculocutaneous motor supply is the anterior arm. Axillary nerve motor supply is deltoid and teres minor muscles. So again, you can see that up here because there's that axillary nerve way up at the top, posterior division. Median nerve, the motor supply is to the forearm and then the thenar muscles. And again, because that goes like through the palm and it's going to diverge into your fingers. Radial nerve is a posterior nerve, and so this is going to supply the extensor muscles. And the ulnar nerve is going to supply the flexor nerves in the front of the arm, and it runs right next to the ulna. So they talk a little bit about carpal tunnel syndrome in your book, and so this, the carpal tunnel is this area in here. So this is the carpal tunnel in here. It's bordered by what are called the flexor retinaculum. So that's this up here. This is the flexor retinaculum right there. And it's just kind of a band of fibers. Here's the flexor retinaculum too. You can kind of see it here. And then it's also got a bunch of bones in there. So all of the bones of the wrist. So carpal tunnel syndrome is when you have inflammation, which is just swelling and just relative pissed offedness of the bones and the nerves there. And so what this can do is it can press on nerves inside of the carpal tunnel because there's not a ton of space. There's not a ton of space between the bones here of the carpal tunnel and that flexor retinaculum. So if this fills up with fluid or if something gets inflamed and kind of mad, what's going to happen here is that those nerves are going to get pressed on because there's not really a lot of place for that fluid to go. It's going to get trapped by those borders. And so carpal tunnel syndrome usually will result in sensory and motor loss where that median nerve supplies, because here's the median nerve. And again, if you remember, looking back, let's go back here to where the median nerve supplies. So median nerve right here, going to run down the hand. And so that carpal tunnel is right in here, right in that area. So that's going to cause numbness and tingling, and it can also cause atrophy of the thenar muscles, those palm and then thumb muscles, if you have a really long chronic case of carpal tunnel. So the way that you treat this is with surgery, what they're doing here, so they can actually release some of those tendons and then release some of the pressure in there. You can go to chiropractic care where they can kind of realign some of the bones and get that carpal tunnel kind of like an impinge so that way the fluid can leak out. Or what's called a cock-up splint, which is a splint that you wear on your wrist. It covers up half of your palm, and then your thumb and your fingers stick out of it. And so it just decompresses the area to allow things to move around there. All right, so lumbar plexus, sacral plexus. I'm going to run through these really quickly. So here is this lumbar sacral plexus. So look what we've got here, L4, all the way down through the coccygeal nerve. We've got all of these networks here. You have big nerve fibers that are going to come off here. The biggest one here is the sciatic nerve. So look at how big that puppy is. There's the tibial branch, and then also the common fibular branch. And so this together makes the sciatic nerve. That's going to run down on the back of the leg. You can see the sciatic coming down through that greater sciatic notch of that os coxae bone right here. Going to run down, and it's going to innervate the back of the leg and part of the buttocks. And so if you've ever had your butt pinched, or if you've ever had your sciatic nerve pinched, you know that hurts like crazy. On the front here, you've got these plexes right here, so L1 through L5. This makes the lumbar plexus, and this guy over here is the sacral plexus, and then together they are the lumbosacral plexus. This is going to feed mostly the anterior part of the leg, and so there's your saphenous nerve, big old nerve, medial part of the leg. You've got the obturator nerve right here, so this is going to supply the medial portion of the leg. And then you also have the femoral branches, and so the femoral branches are right here, big old branch, and those are going to supply, again, the anterior of the leg. So again, some of those bigger nerves include the genitofemoral nerve, and so this supplies what's called the cremasteric muscle, or the cremator muscle, or the cremaster muscle, excuse me. And so this is going to supply muscle motor muscle movement to the testes, and it actually causes that cremaster muscle will actually pull the testicles up as a reflex, or when you get cold, and so that helps to control the temperature of your sperm cells, if that's the kind of plumbing you got. And then the sensory, as the name would imply, goes to the genitals. So this is the anterior scrotum, and then over what's called the mons pubis and labia majora in females. So the mons pubis is like directly before your labia start. There's a little mound of kind of fatty tissue there. That's the mons pubis, and it's usually covered in pubic hair. So if that helps give you some geography of like where that might be. Obturator nerve, again, inside of the leg, medial portion. Adductor muscles is what the motor supply is. Sensory is the skin over the medial thigh, so inside of the leg. And the femoral nerve passes behind that inguinal ligament, and so motor supply is the quadriceps. Sensory supply is anterior leg. Okay. Sacral plexus is mostly posterior, so superior gluteal nerve and inferior gluteal nerve both supply gluteal muscles. The sciatic nerve, that really big one that's got the tibial and then the common fibular, emerges through that piriformis muscle and then travels through that greater sciatic notch of the os coxae, and it is going to form, when it branches again, the common tibial, or the common fibular, and then the tibial nerve. And so this mostly innervates the back of the leg. Oh, I already talked about all that good stuff. So now let's talk about reflexes really quick, and then we're going to talk about autonomic nervous system, and then we're done. So reflexes are, just really simply put, kind of an automatic movement that is hardwired. So the structural unit in the nervous system is a neuron, and so the functional unit of the nervous system is a reflex arc. It's really simple. It just receives a stimulus and produces an automatic response immediately. And so things might be like the swallow reflex, pain reflex, where you go away from pain, and all kinds of other ones that we'll talk about here in a second. So there's 5 basic components of a reflex arc. There's going to be a sensory receptor that's going to receive information. There's going to be a sensory neuron that's going to travel that action potential that was created by the receptor. An interneuron, which, let me point these out here for you. So here's the sensory part. So we've got our sensory receptor way up here, going to receive information. I'm going to start an action potential that's going to run down the sensory neuron right here to that dorsal root ganglion. Going to run back through the gray matter, the sensory part of that gray butterfly. And then here, this little guy right here is the interneuron. So we're going to synapse onto an interneuron. That interneuron is going to synapse onto a motor neuron. So then we're going to send that action potential out to the effector. In this case, it's a muscle, a skeletal muscle. So it's going to cause that muscle to contract or to fire. So this kind of bypasses the integration of the brain, and usually that's because these have to be done very quickly. These reflexes need to be done very quickly. So they're controlled really by the spinal cord itself, and that very simple reflex arc. So again, all that's happening here is you're receiving sensory information, and that information is going to basically boomerang back through your spinal cord and then down a motor neuron, and then you're going to do something. So there's going to be an effector. So types of reflexes that you might see are developmental, so they can be innate, some that they're born with, so like a suckling reflex in a baby, where you like touch the side of their cheek, and they'll like turn towards the stimulation. That's a reflex. Or acquired, and so these can be like riding a bike, driving a car, and those are learned. You don't come out of your mother's uterus knowing how to do those things. You have response reflexes, which can be somatic or visceral, so control skeletal muscle movement or control guts, and so like cardiac muscle movement. You also can have complexity of circuit, so these can be what are called monosynaptic, meaning that there's only one synapse, and so there's going to be a sensory neuron that synapses directly onto a motor neuron, and so there's only one synapse there. Or they can be polysynaptic, and so this one that we looked at here before, this is a polysynaptic one, because we've got one synapse at the interneuron, another synapse on the motor neuron, and so we've got 2 synapses here, and so that's going to be polysynaptic. And you can also have processing site, and so spinal reflexes are processed at the spinal cord, like the one that we were just looking at, and that includes things like stretch reflexes or cranial reflexes, which are processed in the brain. So just depending on where that stimulus is coming from, it's going to probably kind of determine where those are integrated and where they're looked at. All right, so let's run through autonomic nervous system here just real quick and dirty. So autonomic nervous system is again automatic running in the background, things that you don't have to think about. So it's often referred to as the involuntary nervous system. So this is part of the peripheral nervous system because the neurons that support these autonomic nervous systems are part of the peripheral nervous system. So we looked at that sympathetic trunk ganglion. They're outside of the central nervous system. And so autonomic nervous system is divided into what's called the sympathetic nervous system and the parasympathetic nervous system. So sympathetic nervous system is what is turned on when you're stressed out. So it's going to get turned on when you get scared or when you have stress or when you are freaked out. This is also called the fight or flight system. A lot of books refer to it as the 4 Fs, which is fighting, fleeing, feeding, or mating. So that's funny. Hope you guys laughed at home. So fighting, flighting, feeding, or mating. That's your 4 Fs. And then the parasympathetic division, this is your rest and digest autonomic nervous system. So this is what is under control when you are under normal working circumstances. You're not stressed out. You're just sitting at home on your couch watching TV, resting and digesting. So this is a non-stress system. So the autonomic nervous system versus the somatic nervous system is going to be different in that they both have motor fibers, but the effectors are different. So somatic nervous system is going to innervate skeletal muscles. Autonomic nervous system is going to innervate involuntary muscles like cardiac, smooth, and glands. The efferent pathways and the ganglia are a little different, so they're going to run through those spinal nerves differently. And the target organ and the responses to the neurotransmitters is also going to be different. So especially when you're talking about acetylcholine, this is like the classic example. So in the somatic nervous system, acetylcholine, we have at neuromuscular junctions, is always stimulatory, meaning it always results in muscle contraction. But in the autonomic nervous system, the effect can be either stimulatory or inhibitory. So meaning that it's going to retard the gland or the muscle's ability to fire. And so it'll be inhibitory, making it less likely that an action potential is going to fire. So the efferent pathway, so again, efferent means that it's going from the central nervous system to the effectors. So we're going away from the central nervous system. So in the somatic nervous system, you have cell bodies that are located in the central nervous system. And in the autonomic nervous system, they can be within the central nervous system or outside of the central nervous system. And so we'll look at pictures of that here in just a second. But I wanted to show you guys too. So you've got, again, autonomic nervous system here, so parasympathetic, and then you've got sympathetic. And so we also have the somatic or the voluntary system. So in somatic systems, these neurons are heavily myelinated. Cell bodies are located in the central nervous system, heavily myelinated, and these are going to affect muscles. Sympathetic, autonomic nervous system, sympathetic division, lightly myelinated cells. You might have multiple synapses here, or they might synapse directly onto a gland, especially in the case of the adrenal glands, where you tell them, quick, throw out some norepinephrine, or throw out some epinephrine so that we can get excited and we can run away from the thing that stressed us out. So we're going to have norepinephrine here as our neurotransmitter. And then in the parasympathetic, again, we can have polysynaptic here. So then we're going to have acetylcholine, and acetylcholine used as the neurotransmitter for smooth muscle movement, cardiac muscle movements, that sort of thing. So that's some of the very basic differences between the somatic nervous system, voluntary somatic nervous system, and then the autonomic nervous system. So the parasympathetic division, again, your rest and digest, got that written down right here for you, rest and digest. This is going to be where you conserve energy, promote digestion, is active in non-stressful situations. So sitting on your lazy boy, watching your reality TV at night on Bravo, whatever. The origin comes from cranial nerves, so 3, 7, 9, and 10, and then also sacral segments 2 through 4. So that sacral plexus that we were looking at just a little bit ago. So the location of ganglia, the swellings where the cell bodies are what are called terminal ganglia. So these are near or within a target organ. So that means they're actually going to synapse onto the organ or very, very close to it. And I'll show you pictures of that here in a little bit. The length of the fibers are really long before that big swelling of swelling of cell bodies. So those are called long preganglionic fibers, and very short postganglionic fibers. And again, I'll show you pictures of that. I know those are like big, scary words. Neurotransmitters include acetylcholine, which can be stimulatory or inhibitory. And then these will distribute or diverge not in the same way as the sympathetic nervous system. So these don't diverge as much, and the effect of these neurons is much more localized and specific. And so that's called discrete activation, so very specific. So here's the parasympathetic division. So we've got, again, there's our cranial nerves that are involved here. Rest and digest, and so we've got, this is the ganglia right here. This is where the ganglia would be. So those cell bodies are going to be amassed. So we have really long preganglionic axons, which is what they're talking about here. So preganglionic, and then we have relatively short postganglionic axons here. So relatively short on this side. So you can see right there. So again, they can synapse really close to the effector organs, like we see up here. Synapse really close to the organ, or they can actually synapse just directly on top of the organ or within the organ. So that's parasympathetic division. The sympathetic division, this is your stressed out fight or flight response. And so this is going to do kind of the antagonistic effect of the parasympathetic. It's going to turn on your stress response. And so this is going to be originating in the central nervous system. The physiological effects are, again, fight or flight. So again, the 4 F's: fighting, flighting, or fleeing, feeding, or mating. So that's your last F there. So this is going to stimulate your metabolism, increase alertness, prepare your body for an emergency, like you have to either fight or flight to get away or get out of that situation alive. Location of those swellings are really, really close to the vertebral column. So I'll show you what that looks like here in just a second. There's a little bit of a difference in the nerve fibers. They have really, really short preganglionic fibers. So this is opposite what we saw in the parasympathetic, and really long postganglionic fibers. Neurotransmitters that are involved here are acetylcholine and norepinephrine. Both of these are stimulatory in this nervous system. And then the distribution of those neurofibers are going to go from, like, one neuron are going to synapse on a whole bunch of other cells. And so this is called mass activation. And so this is going to diverge, and it's going to excite a whole bunch of cells, so causing a really large scale response. So here's that sympathetic trunk. So you can see that here, and then we've got the ganglia. And so this is going to be the postganglionic cell here, or the postganglionic axons here. So much longer. And then you've got, again, these swellings, and then you've got the preganglionic fibers here. So what that looks like is you've got the fibers here, and so the preganglionic fibers are going to be really short, like you can see here, and then the postganglionic fibers are going to be really long, so really long. And then we've got other ganglia here that are going to synapse onto the organs and the effectors. One difference here is that you can see we've got these nerves coming in. You can see that the one that goes to the adrenal medulla is kind of a hard wire. So that one actually doesn't really synapse on anything. It's just like got a hard wire direct line to the sympathetic trunk. And that's because the adrenal medulla is going to produce your epinephrine and your norepinephrine. So those are stimulatory in action, and they're going to get the rest of your body prepared for fighting or flighting. And so there is one hard line in there. So, like I just said, so the pathways that synapse in the adrenal medulla, so these are going to just go directly to the adrenal medulla without synapsing. It's just a direct hard line in there. And so once you stimulate that, you're going to put a whole bunch of norepinephrine and epinephrine into the blood, and that is going to cause your other tissues to get excited, my friends, really excited. So some of the interactions that you see with the parasympathetic and the sympathetic, so your fight and flight, rest and digest, are that most of your organs are going to have what are called dual innervation. So they're going to have axons that come from both of these systems. And so the action potentials are going to fire continuously down axons of both divisions, but it's going to cause what's called an antagonistic interaction. And so that means that they're opposite. And so this is going to work really well to really help control your visceral activity. So what's going on in your heart, what's going on with your digestive system. And when you've got your autonomic nervous system, both of them are kind of partially active, that is going to result in something called basal sympathetic and parasympathetic tone. So we're really, what that tone means is that we're kind of ready to go immediately upon arousal for either of those. And so sympathetic nervous system, turn it on just like that. Parasympathetic, you can also turn it on. So depending on what's going on in your environment, you can turn them on independently of one another. One of those is usually going to predominate. So either one of them is going to be turned on or the other. So sympathetic if you're stressed out, parasympathetic if you're resting and digesting. One of them is usually going to take control of the other one, so it's going to be the one that's more turned on. But in very few cases, you can have divisions that are having what are called cooperative effects, where they're actually working together to get some of your body systems up and going. So these are just the antagonistic and cooperative effects. And so the antagonistic interactions, again, allow for precise control of visceral activity, and you can see some examples there. And then cooperative effects can be seen, they talk about this in your book, is control of the external genitalia. So the parasympathetic fibers cause vasodilation, which is responsible for how men get an erection in their penis or how women get an erection in your clitoris. Learn something new every day, don't you? You didn't know that you could get a little bit of an erection too, even if you're a female. And then the sympathetic fibers, because that's the mating part of the sympathetic nervous system, causes ejaculation and then also reflex contraction of a female's vagina, which can stimulate an orgasm. So, whoop, whoop, like, let's hear it for the sympathetic nervous fibers. Hooray. So control of the autonomic nervous system is from control centers in the central nervous system. And so that includes brainstem, spinal cord, hypothalamus, and cerebral cortex. And the hypothalamus is really the main integrative center here. And so it's going to take information from the rest of your body, all those sensory neurons, and kind of decide how to generate motor output for that and generate glandular output for that. You can override, like if you get, for example, like if something were to move in the dark and it scares you really bad, and you can tell that you get like kind of, whoa, oh my God, but then you realize that it's just your cat moving around in the dark. So cerebral input, where you associate your cat with being like not scary, can help you calm down that sympathetic response. And so that's the cerebral input that they're talking about here. And so you might receive other information that tells you that indeed this situation is not scary or as necessary for fight or flight as I thought. That is done subconsciously, but it does come from the cerebrum. So they did make a point of that in your book. So that's it for the rest of chapter 13 and 14. I'll end that here. And if you have any questions, feel free to email me, as always.